At the outset, I would like to thank Aios ARC for this invitation. And I will take my talk starting from the conclusion slide with Dr. Padma so nicely showed. So uveitis is a challenge for clinicians. I'm sure everyone here today will agree with me, because there are numerous possible etiologies, each requiring different treatment approaches. Every patient is unique. We don't know how that patient seated in front of you will react to the given treatment. And in addition to the adverse effects of the disease, you also have to deal with the adverse effects due to the drug itself used to treat the disease. So addressing uveitis requires a lot of trial and error. And definitely, I do agree. The ultimate goal is to preserve vision. And for this, there should be no inflammation in the eye. However, I wish things were so simple as black and white, but in reality, it is not so. And many times in our practice, we have to understand this and say mild inflammation is still okay. Now, I will be showing a few case examples which will highlight this aspect. So let me take the first case. This is a 10-year-old girl with idiopathic pars planitis with only one eye involvement, labs non-contributory, who had failed conventional immunomodulation. And when I saw her, she was already on adalimumab for 2.5 years. Her best corrected visual acuity has always been 6.6. Now, when you see her fluoresceint angiogram, she still has extensive retinal vascular leakage with adalimumab. So it was very tempting because just then I had published a paper with tocilizumab and I said, let's try tocilizumab in her. And the rheumatologist also agreed and we started tocilizumab. 3 months down the line, I thought she was doing well, but to my horror, 7 months later, the vascular leakage was still the same. And more than me, the parents were very disappointed because they had spent a bomb for the tocilizumab. And eventually they convinced me to get her rid of all biologics. And today she's on methotrexate and mycophenolate, and still her vision is 6.6 with no cystoid macular edema. Now, to highlight another similar case, this is a Sri Lankan male who had come for, I think, a 4th or the 5th opinion. And he was already on an MMF and cyclosporin, again, pars planitis, bilateral with good vision. And when I look at his FFA pictures from 2013 till 2017, all of them are similar. And he said everything is the same. So I will continue MMF and cyclosporin. And he refused adalimumab. So his vision is still 6.9. So this patient still has vascular leakages, but clinically his eyes, the fundus looks okay. And fluoresceint angiogram and OCT has not worsened. Now, look at the third case. This is a 72-year-old lady with rheumatoid arthritis, and she was already on methotrexate 12.5. And she was referred by her rheumatologist for an ophthalmology consult. So when I saw her, she had a history, her records show that she had a history of scleral melt in the right eye, which was treated with buccal mucosal graft 2 years ago. And her left eye, she had this peripheral corneal melt. And, everything was negative for infection. And normally when we see a pattern like this, we are very aggressive. So my gut feeling was, let's start her with IV methylpred with IV cyclophosphamide, although reluctantly we went ahead with cyclophosphamide, especially considering the age. So she had 3 doses and I thought she was doing better. But eventually, after 3 injections of cyclophosphamide, she came back to me with a hypopyon. And her vision also had dropped in that eye. And when we did a tap, it turned out to be a secondary infection. So she was put on systemic steroids. So at this point of time, we thought we'll withhold the cyclophosphamide and keep her on a very, very slow taper of oral steroids and increase the methotrexate. Eventually, she did well, and it took her some time, but things started getting better. And from the eye point of view, she started doing very well. However, she developed cough. And when I did her CT, she had multiple lung nodules. And this was something like a MET. And when we did a PET CT, I was horrified to see that she had a breast carcinoma with metastasis in the lung. And probably the cyclophosphamide and all these immunomodulators with thing could have hastened the progression. Now, unfortunately, because of the steroids which she was on, she developed her blood pressures went high, and she developed a stroke as well. Unfortunately, the only good eye which was there in the right eye, which had a 618 vision, now had a counting fingers close to face because the nerve was involved. So sometimes it is important to take into account the age, especially when we are treating such, treating aggressively with these medications. My case 4 is a patient with Wegener's granulomatosis with refractory scleritis and orbital pseudotumor. Unfortunately, he had reached the maximum cumulative dose of cyclophosphamide, and hence we could not give cyclophosphamide. We were unable to reduce the oral steroids to less than 20 milligrams per day. And as per his rheumatologist, the systemic disease was stable, but it was only the eye which was involved. So at this point of time, weighing the pros and cons, we decided to go ahead and try rituximab. Unlucky for us, he developed worsening of inflammation. And this was one of the early cases of rituximab with worsening of inflammation. And he developed again fluid in the posterior subtelian space and scleritis. And eventually he had to receive IVMP and very slow taper of oral steroids. So eventually we have been able to get him down to 5 mg of steroids, but I know the disease is still there because he continues to have choroidal thickening and he gets vague inflammations now and then. Though this is not the actual protocol, we kind of stagger the rituximab infusions, and we give it now with a little more higher pre-med of solumedrol with the rituximab to prevent worsening of inflammations. So we know that the disease is still mild. I mean, it is still present, but right now we have been able to balance both sides. Unfortunately, we do not live in a utopian society, and definitely management of uveitis is an economic burden to these patients. And the newer drugs now come with a huge price, and these are not covered by insurance or any of the government schemes so far. I will just show you a last example. This is a 5-year-old girl with oligoarticular GIA, and she was on oral steroids and injection methotrexate for the last 2 years, but continued to develop inflammations in the eye. Now, this kid could not afford adalimumab, though this would have been the best choice for her. And so we had to just add something else which would at least reduce the amount of inflammation, much better than what we were seeing then. So we added mycophenolate along with this. And though the inflammation did come down, definitely it was not no inflammation. And she also started developing recurrent joint swellings as well. So the disease was still active. Fortunately for her and us, the tofacitinib had lost their patent and Cipla was marketing it at a very low price. And we decided to try that in her. So though it was not as great as what we would see with adalimumab, but definitely the inflammation is much better. And this is one of the perks which we can see when we use biologics. But again, cost is a huge concern. So to conclude, ideally, it would be best if there is no inflammation. But in reality, there are multiple factors which govern the management, which includes the etiology, associated systemic diseases, adverse effects of the drugs, and most importantly, the cost. So the responsibility definitely lies in us to balance between the risk and the benefits. And in this aspect, I would still feel mild inflammation is still okay. Thank you.
Thank you very much, Dr. Kalpana. I think uveitis, intermediate uveitis is a situation which keeps challenging us. And I'm going to take a question with Dr. Avinash, and I seem to be harping on the pediatric age group. But however, I wanted to know that in this particular age group, at least, if the inflammation is mild, would we let go, or we would be as aggressive as we would be with the adults, even with mild inflammation?
Right. Thank you, Dr. Murthy. Your question is very relevant. So pediatric age group is a different ballgame and subject altogether, where though the primary goal elicited by both the speakers have been very clear. So, but pediatric age group is one such where sometimes the conventional treatment may not work, and going behind to control the inflammation as much as possible. The ideal scenario is envisioned more in pediatric than in adults, because they are able to take anti-inflammatory therapy as much as possible in that age group. So if you have to push the button hard, it could be in the pediatric age group than in an elderly population, was what would be in my practice.
Dr. Srinivas?
Madam, excellent talk by both of you. Wonderful. My question was, say, when you are putting the patient on the methotrexate and if there is a very minimal or the mild inflammation. So when do you consider switching these patients or adding the biologics in these patients? When the first line indication for starting them on biological?
It's directed to
Whom are you asking?
Yeah.
Krishnas or the speakers?
Whom to is directed to me.
Anyone, sir. You can just go ahead. You can start.
So I think is that a mild inflammation you can persist, and we need to really think about that the side effects of the drugs also. So I keep the patients on methotrexate until unless it's really is a problem of that one. There's a persistent flare and looking at the macula or the vascular leakage is there. I have got a patient which I'm seeing for last 5 years. She had intermediate uveitis. Every time I do the fluorescent angiogram, I see the capillary fardening, but the patient is still maintaining good vision in spite of all the immunosuppressive agents failure in the capillary fardening. So he was on cyclosporine and then mycophenolate, and now he's on the injection adalimumab. Still the patient is having capillary fardening. So sometimes there is no really is a end point, like zero effective is zero end point to reach the inflammation. So it's not really practical. But we need to be careful about the macular region, any fluid accumulations over there, like doing an OCT in such cases.
Srinivas, can I ask a question to both Padma and Kalpana actually?
Yeah, please, sir.
How would you define, both of you, how do you define mild inflammation in your practice?
Mild will be traces of cells in the anterior chamber or the vitreous haze 1 plus or haze 0.5.
So 0.5 haze and cells 1 plus or less.
Yes.
I think it also depends on, Avinash, like the entity which you're actually looking at. You know, like, for example, JIA and all that. As what Padma said, you know, even a flare will be a little, I mean, I would like to control that as much as possible. Whereas if it is something else, like, you know, which is an idiopathic recurrent anterior uveitis, I wouldn't really worry that much in terms of, you know, the mild or, you know, that kind of thing. But in a JIA where I see a BSK already coming in, that is something where the disease is still active. Similarly, in kind of VKH or so, if I see choroidal granulomas on FFA, it's still not mild. No, it's like it is definitely an important thing, you know, parameter which we need to take. So I think that kind of mild or so depends on the entity which you're dealing with.
And also mild in children is dangerous than mild in adults.
Yeah.
So children, very, very difficult because invariably they go for band-shaped keratopathies, cystoid macular edema, vasculitis, opaque vitreous. So in children, it is better to be little more aggressive than adults.
Thank you so much.
What would you do, Dr. Avinash?
No, I think for mild inflammation, again, the comorbidities what Kalpana was mentioning is, though I had mentioned about the children, is already, I'll push the button hard for aggressive inflammation, but the comorbidities which can happen, that's the time when I would go in for a sort of aggressive treatment in such kind of cases. But having said that, the worst experience I ever had was of even before the COVID set in was a case of mucormycosis in a diabetic patient who was immunosuppressed uncontrolled. So those are things which you occasionally we get to see, those where, you know, it'll make us rethink about our clinical practice for some time at least.
Yeah.
Yes.